Now we are going to talk about a 46XY DSD. Now in a 46XY DSD, we can divide all the types of DSDs into two categories. First category is a DSD which is related to testicular development. So there is abnormal testicular development. And this abnormal testicular development could happen in the form of pure gonadal dysgenesis. Pure gonadal dysgenesis with a 46XY karyotype. A pure gonadal dysgenesis in which the karyotype is 46XY. Gonadal dysgenesis means the gonads are not functioning, right? Normally in a 46XY individual, the gonads should be testes and testes should be functioning. So suppose if the testes are not functioning, that becomes a DSD. Right? And this is seen in pure gonadal dysgenesis where the karyotype is 46XY. Earlier, a pure gonadal dysgenesis with karyotype 46XY was called as Swyer's syndrome, and some of the questions still they may ask about Swyer's syndrome instead of saying pure gonadal dysgenesis with 46XY karyotype. Or it could be a partial gonadal dysgenesis, or it could be that instead of only testes, this individual has ovaries and testes, or it could be that there is testicular regression. So all these are varieties of 46XY DSD in which the testicular development is not happening properly. It could be a pure gonadal dysgenesis, it could be a partial gonadal dysgenesis, it could be testicular regression syndrome, or it could be ovotestes. A second category of DSD is normally in a 46XY individual, androgens should have been produced. Now suppose if there is a problem in androgen production or if there is a problem in androgen receptors, right? Then also that is taken as a 46XY DSD. This could happen in androgen insensitivity syndrome. So as the name suggests that androgens are being produced but the individual is insensitive to androgen. There are three types of androgen insensitivity syndrome: complete androgen insensitivity syndrome, partial androgen insensitivity syndrome, and Riefenstein syndrome. The second DSD could be that the individual is producing, a 46XY individual is producing less androgens. And just now we saw in congenital adrenal hyperplasia due to 17-20 lyase deficiency and 17-alpha hydroxylase deficiency, or congenital adrenal hyperplasia due to 3-beta HSD or P450OR deficiency leads to decreased androgen production in intrauterine life. Or the problem could be due to problem in the receptor. That receptor could be anti-Mullerian hormone receptor. So if there is a problem in anti-Mullerian hormone receptor, the anti-Mullerian hormone will not act, and because anti-Mullerian hormone will not act, so in this 46XY individual, you are going to get persistent Mullerian duct, which is called as persistent Mullerian duct syndrome. So normally in a 46XY individual, Mullerian duct should regress. But suppose in an XY individual, there is a problem with anti-Mullerian hormone receptor, so there is persistent Mullerian duct syndrome. Or if there is a defect in HCG or LH receptors. Why am I saying HCG or LH receptors? This is because the first stimulus for the testes to produce testosterone is HCG. Right? In testes, it is the Leydig cells. Remember, in testes, there are two types of cells, Sertoli cells and Leydig cells. Right, so it is the Leydig cells which produce testosterone under the influence of hormone LH. Right, but the first stimulus for the testes to produce testosterone is not LH. The first stimulus is HCG. So if there is a male in whom there is a problem with HCG receptor or there is a problem with LH receptor, it is going to lead to defective testosterone production, and again that is a type of DSD. Or suppose everything is normal with testosterone production, testosterone gets converted into dihydrotestosterone with the help of enzyme 5-alpha reductase. So if there is a deficiency in 5-alpha reductase, then that is also a DSD. Right? So anything which is related to androgens, where the androgens are either the male is becoming insensitive to androgens, or suppose androgen receptor problem is there, that problem could be LH receptor problem, HMG receptor problem, or the problem could be that the testosterone is unable to convert into dihydrotestosterone. All this comes under 46XY DSD. Have you understood? Now we are going to do details of each one of them. So the first thing which I told you, the first DSD which I told you was that in a 46XY individual, if the testes are not functioning, which is pure gonadal dysgenesis or Swyer's syndrome. What happens in Swyer's syndrome, I'm going to tell you. But before that, if you remember, at the beginning of the video, I told you that you should watch the normal sexual development video and you should watch the video on puberty. Then you will be able to understand all these concepts. Quickly, I am taking you through what is important, which you have to remember in the puberty video, the concepts from puberty, which you are going to apply over here. So in the video on puberty, I told you that if the individual is a 46XX individual, the gonads will be ovaries and ovaries are going to release estrogen. And it is this estrogen in females which leads to the development of secondary sexual characteristic, that is breast. So in females, the role of estrogen is not on external genitalia, right? The role of estrogen are two. What is the role of estrogen? Number one role of estrogen, it leads to the development of breast in females. And this happens at puberty because ovaries are going to produce estrogen at puberty. Right? That is number one. Number two, estrogen is the one which leads to proper growth of uterus, cervix and vagina. Right? So uterus, cervix and vagina, they are formed from Mullerian duct. That is there. But their proper growth is going to happen because of estrogen. So in gynae physio integration, I told you that it is estrogen which leads to the growth of non-pregnant uterus. Right? Now, this is what is important in a female. You have to remember that in females, from puberty onwards, ovaries are going to produce estrogen and estrogen is going to perform two functions. Now, in a female, apart from breast development, at the time of puberty, you also see that her axillary hair and pubic hair are growing. But remember that the growth of axillary hair and pubic hair is not dependent on estrogen. It is dependent on testosterone. And from where does these androgens or testosterone come in a female? The androgens or testosterone in a female come from two sources. Number one, ovary. The theca cells of ovary produce androgens. And number two, the adrenal glands. So in a female, for breast development, the hormone which is needed is estrogen, whereas for pubic hair and axillary hair development, the hormone which is needed is androgens. Now, when we talk about males, in a male, that is a 46XY individual, the gonads are testes and testes produce testosterone and dihydrotestosterone. It is this testosterone and dihydrotestosterone which leads to secondary sexual characteristic of a male. And what are the secondary sexual characteristic of males? Deepening of voice, increase muscle mass, right? Then hair growth in areas like chin, on neck, on upper lips. All these are secondary sexual characteristic in males. And for all this, what is responsible? For all this, androgens or testosterone is responsible. Obviously, in males also, for axillary hair and pubic hair, what will be responsible? Testosterone or androgens would be responsible. Right? So this was the concept which you had to remember from puberty. Now, if you've understood this concept from puberty, now I am going to take you through each of the problem which can happen in a 46XY individual with DSD. So the first problem we are going to talk about is Swyer's syndrome, which I told you nowadays is called as pure gonadal dysgenesis with 46XY karyotype. So in Swyer's syndrome, the genotype or the karyotype is 46XY. And I told you in normal sexual development that whenever Y chromosome is present, the gonad has to be testes. The problem is that in these individuals, the gonads are dysgenetic. It is pure gonadal dysgenesis. That is, these gonads are dysgenetic. The testes are not functioning. Dysgenetic means testes are not functioning. And why have they become dysgenetic? They have become dysgenetic either due to mutation in SRY gene, or due to a mutation in SOX9 gene, or due to a mutation in DAX1 gene or SF1 gene, right? So due to mutation in any of these genes, the testes have become non-functioning. Now, if testes have become non-functioning, obviously the Sertoli cells have become non-functioning and the Leydig cells have become non-functioning. Now, when Sertoli cells have become non-functioning, so anti-Mullerian hormone will be absent, and because anti-Mullerian hormone will be absent, in this 46XY individual, Mullerian duct will grow and it will lead to the formation of uterus, cervix, fallopian tube and upper vagina. Right? So in this 46XY individual, the Mullerian duct is growing and you are seeing that uterus, cervix, fallopian tube and upper vagina are present. Now, because Leydig cells are not functioning, that is why testosterone will be absent, and because testosterone will be absent, Wolffian duct will not grow, and so male internal genital organs, that is SEED, would be absent. Now, because testosterone is absent, so there won't be any dihydrotestosterone, and if there won't be any dihydrotestosterone, no dihydrotestosterone, so external genitalia will be exactly female-like. Please do not say that in Swyer syndrome there is ambiguous genitalia. No, there is no testosterone, there is no dihydrotestosterone. So the external genitalia without any hormonal influence, they are always female external genitalia. And that is why these individuals are taken as a female child at birth. Now, these testes, or if there is no scrotum, obviously, and there is no testosterone, no dihydrotestosterone, remember, it is this anti-Mullerian hormone, testosterone, and dihydrotestosterone, basically the two, the anti-Mullerian hormone and testosterone, which helps in the descent of the testes. So if there is no anti-Mullerian hormone, there is no testosterone, the testes are undescended and they are palpable in inguinal area. And that is why I told you, whenever you are getting a phenotypically female looking child or female external genitalia. But the problem is that there is a female external genitalia, but the gonads are palpable. Those gonads could be palpable in the inguinal area as well. Then you should always suspect that the genotype could be XY, right? And these individuals, why are they going to come to me? They are going to come to me that as a case of inguinal hernia. They are not going to come and tell me that I have gonads in inguinal area. No. These children who are taken as a female child, as they will grow, their parents will notice that there is some hernia-like thing in the inguinal area. So they are going to bring the child to you as a case of inguinal hernia. That is when you have to realize that you are palpating the testes, and that is the time when you are going to do their karyotyping. Right. Now, as I told you, undescended testes have increased chances of malignancy, and so I will have to remove them. Okay. So now my question to you, which I asked you just now a few minutes back also, that if there is a 46XY individual, but the genitalia are looking exactly like female, how do you suspect a DSD? You suspect a DSD because the gonads are palpable, right? And whenever this happens, you go for karyotyping. So please remember, whenever the gonads are palpable and the external genitalia are female-like, that is an indication for karyotyping, or vice versa. The gonads are not palpable and the external genitalia are looking like a male, right? Then you should go for karyotyping, right? Now, let's come back to this child. So this child of pure gonadal dysgenesis, that is Swyer syndrome, because the external genitalia were looking exactly like female, we assigned the gender as female at the time of birth, right? Now, this child is going to grow and reach puberty. Now, at puberty also the child has non-functioning testes. So, if the testes are not functioning at puberty also, they will not produce any testosterone. And if they will not produce any testosterone, there won't be any secondary sexual characteristics of males, right? Now, obviously, they are testes, so they are not going to produce any estrogen. And if there will be no estrogen, so there won't be any secondary sexual characteristic of females also. That means this individual who was taken as a female child was expected that at the time of puberty, this child is going to have breast development, right? But because this child is XY with a non-functioning testes, they do not have any testosterone, they do not have any estrogen, so they won't have any breast development, right? And because they don't have any estrogen, and just now I told you, estrogen was required for proper growth of uterus, for proper growth of cervix and proper growth of vagina. So in this child, the uterus will be not properly developed, it will not grow, and it will be resembling infant-like uterus, and that is why we say the uterus is infantile. Now, this child who was expected to have menstruation also, because she was taken as a female child, obviously there is no ovary, there is no estrogen, there is no ovulation, no progesterone, so they are not going to have any menarche also. So the parents are going to bring this child to you as with complaints of either primary amenorrhea or with the complaint of delayed puberty. Is this clear to you? So this child can come to you as a case of inguinal hernia, right? Or she can come to you as a case of primary amenorrhea or as a case of delayed puberty. Tell me, what are you expecting the LH and FSH levels in this child? Although I have written over here, I'm writing it again. Now, because the testes are not functioning, so there is no testosterone, there is no estrogen, and if there is no testosterone or estrogen, the negative feedback on GnRH is not there. And so what happens to the levels of LH and FSH? The levels of LH and FSH are high. So in case of Swires syndrome, LH and FSH levels are high, right? Now, when you are going to do ultrasound in them, what are you going to see? When you are going to do ultrasound in them, you are going to see that yes, uterus is present, but you are also going to see that there are undescended testes. And when you are going to do lab investigations, what are you going to see? On lab investigations, you are going to see that the testosterone levels are decreased. Sertoli cells, they produce inhibin B, right? So, Sertoli cells produce inhibin B in males, right? Leydig cells, they produce testosterone in males, right? FSH is the one which acts on Sertoli cells. FSH acts on Sertoli cells. Sertoli cells, they produce inhibin B. LH acts on Leydig cells, and Leydig cells produce testosterone. Inhibin has a negative feedback on FSH, whereas testosterone has a negative feedback on GnRH, and it has a negative feedback on LH also, right? So this is how, there is reproductive physiology in males. That FSH acts on Sertoli cells produce inhibin B, and inhibin B has a negative feedback on FSH, whereas LH acts on Leydig cells produce testosterone, and testosterone has a negative feedback on both GnRH and LH. So in patients of Swires syndrome, Sertoli cells are not functioning, Leydig cells are not functioning. Because Sertoli cells and Leydig cells are not functioning, so levels of inhibin B will be decreased, levels of testosterone will be decreased, whereas the negative feedback on FSH, LH and GnRH are lost. So the levels of LH, FSH and GnRH are high, right? Now, how am I going to manage them? What is the management? See, these individuals, for such a long time, they have been females. Their external genitalia are females. They are coming to you at around 14-15 years with complaint of primary amenorrhea, with complaint of delayed puberty. Now, at this time, if you tell them that no, you are not XX, you are XY, right? Then that is a lot of trauma, not only for the child, but also for the parents as well. So, I'm going to let them be females. That is first thing which I'm going to do. Now, the second thing is that I know that they have undescended testes, and undescended testes have high chances of malignancy. So I'm going to advise them gonadectomy. And what time should I advise them? I should tell them that they should get gonadectomy done as soon as possible because these undescended testes have high chances of malignancy. Third thing. Now, because I am letting them be females and their breast is not developed, right? And because I'm removing the non-functioning testes, so now I have to give them some form of hormone replacement therapy. So what I'm going to do is I'm going to give them estrogen initially for 1 year, and this estrogen I am giving for breast development. Later on, because they have a uterus present, and if I continue giving them only estrogen, they will have increased chances of endometrial cancer, right? So later on, I'm going to give, after 1 year, I'm going to give estrogen and progesterone. For 1 year, give them only estrogen so that the breast develops, and then later on, give them estrogen plus progesterone. And till what age are you going to give them estrogen plus progesterone? You are going to give them estrogen and progesterone till the age of normal menopause. Right? So till 51 years of age, I will continue giving them estrogen and progesterone. Right? Now, if these females, they have a problem in intercourse. Why will they have a problem in intercourse? Because they have Mullerian duct, and Mullerian duct forms only the upper part of vagina, whereas lower part of vagina is formed by urogenital sinus. So they may have problems in intercourse. Now, if they are having problem in intercourse, I am going to advise them a vaginoplasty. And what procedure? The procedure for vaginoplasty is a Weisschetti technique, which is a laparoscopic technique, or Davidoff technique. Right? And what is the time for doing this vaginoplasty? The time for doing this vaginoplasty is just before or just after marriage. Just before or just after marriage. Right? So this is what you are going to do in these individuals, that is Swyer's syndrome. Have you understood 46XY DSD with Swyer's syndrome? Okay. Now, ovotestes, that is another type of DSD with 46XY karyotype, and everything about ovotestes I've done with you earlier. Most common karyotype of ovotestes is 46XX. Then there can be a testicular regression syndrome. Now, as the name suggests, here the testes are going to regress. So, in this patients, in these individuals, the genotype is 46XY, and that is a normal genotype. And because they have a normal genotype, normal Y chromosome, so it was going to lead to the formation of testes. In early intrauterine life, testes is normal in them. And because testes is normal in them, they are going to produce normal amounts of testosterone, and they are going to produce normal amounts of anti-Mullerian hormone. Because they are going to produce normal amounts of testosterone and normal amounts of anti-Mullerian hormone, so internal and external genitalia will be normal. Now, what happens is that due to some problem later in intrauterine life, and that problem could be a testicular torsion, the testes regress. That is, there is anorchia. Right? But then, although the testes are regressing, by this time, the internal genitalia and the external genitalia are already formed. Right? That is why there is no problem in them. So in testicular regression syndrome, you will never get ambiguous genitalia. You will get male external genitalia. The only this is a DSD where you are not getting ambiguous genitalia. This is a DSD where the problem is with the gonads. The testes are regressing, but the internal genitalia and the external genitalia are normal male-like. Clear to all of you? Yes? Then comes a third kind of DSD, which is androgen insensitivity syndrome. In androgen insensitivity syndrome, there are three kinds of problems which can happen. There could be a complete androgen insensitivity syndrome, partial androgen insensitivity syndrome, or Riefenstein syndrome. First, I'm going to talk to you about the most common type, which is complete androgen insensitivity syndrome. Now, complete androgen insensitivity syndrome, it is an X-linked recessive disorder. The genotype is 46XY, and because they have a Y chromosome, that is why the gonads are testes, and these testes are normal testes and functioning testes. Now, because these testes are normal testes and functioning testes, so Sertoli cells are going to form anti-Mullerian hormone, and this anti-Mullerian hormone is going to lead to regression of the Mullerian duct, and it is going to lead to partial descent of the testes. Then the Leydig cells are going to form testosterone, but the problem is that these males are resistant to testosterone. Now, what is going to happen? Now, because they were forming anti-Mullerian hormones, so Mullerian duct had regressed, and because Mullerian duct had regressed, that is why there is no Mullerian duct structure. That means uterus is absent, and that is how it should be in a male. Right? In a 46XY individual, uterus should not be present, and over here also, because the testes are functioning normally, the Sertoli cells are functioning normally, so anti-Mullerian hormone is normal, so Mullerian duct regresses and there is no uterus. That is, uterus is absent, cervix is absent, vagina is absent, the upper part of vagina, and fallopian tube is absent. Now, on the other hand, as I told you, that testosterone is also being formed normally, but these males are resistant to testosterone. So what is going to happen? Now, because these males are resistant to testosterone, so Wolffian duct is going to also regress. So in this individual, there won't be any male internal genital organs. That is, SEED will be absent. Seminal vesicles, epididymis, ejaculatory duct, and vas deferens will be absent. So here we have an individual in whom neither are you going to get any female internal genital organs, neither are you going to get any male internal genital organs. Right? Now, because testosterone and dihydrotestosterone act through the same receptors, and this was one concept which I asked you to remember. Now, because they are testosterone and dihydrotestosterone, they are acting through the same receptors, so these individuals are resistant to dihydrotestosterone also. And because they are resistant to dihydrotestosterone, that is why their external genitalia will look exactly like a female external genitalia, and they are taken as a female child at birth. Please remember, in complete androgen insensitivity syndrome, the genitalia are exactly like a female external genitalia. They are not ambiguous genitalia. The other thing is that these testes, because they are resistant to testosterone, so obviously the testes are not going to descend. They will be partially descending, and they will be palpable in inguinal region. Now, these undescended testes, as I told you, the child can present to you, they can come to you as a case of inguinal hernia, and they have increased chances of malignancy. Always when the testes are undescended or partially descended, they have increased chances of malignancy, and they may present to you as a case of inguinal hernia. Now, again, this child who's born with exactly female-looking external genitalia, what I'm seeing, one thing abnormal which I'm seeing is that their gonads are palpable. So, as a clinician, I can detect this condition at birth only, right? If I am very careful with the examination of the external genitalia, even though they are female, I should get a hint. Whenever I see palpable gonads, I should get a karyotyping done. But suppose I don't get a karyotyping done, I'm not that careful, and this child who's taken as a female child is handed over to the parents, and this child grows up. Now, when they are going to reach puberty, again, the gonads are testes in them, and the testes are functioning normally, right? So, at the puberty also, the testes are going to produce testosterone. Now, as I told you, these individuals are resistant to testosterone, and because they are resistant to testosterone, so male secondary sexual characteristics are not going to develop. So, they are not going to have any deepening of voice. They are not going to have increased muscle mass. And also because the development of pubic hair and axillary hair depends upon testosterone. So in these individuals, pubic hair and axillary hair will not develop and it will correspond to Tanner stage 1 or 2. Now, because in these individuals, the levels of testosterone are high, and this is the difference between Swires and androgen insensitivity syndrome. In Swires, there was no testosterone, and because there was no testosterone, there was no estrogen also. Testosterone can get converted into estrogen with the help of enzyme aromatase. Now, in Swires syndrome, there is no testosterone, so there is no estrogen. In complete androgen insensitivity syndrome, the testosterone levels are high, and all these high levels of testosterone ultimately with the help of enzyme aromatase gets converted into estrogen, right? And these individuals are resistant to testosterone. They are not resistant to estrogen. Because they are not resistant to estrogen, there will be proper breast development corresponding to Tanner stage 4 or 5. Now, this child who was taken as a female child and at puberty is showing proper breast development. So parents don't have any confusion at all about the karyotype, right? They are sure that they are rearing up a female child, and whenever there is a female child, we expect them to menstruate, right? So these children, again, these females will be brought to us with complaint of primary amenorrhea, right? In Swires syndrome, because breast development was not there, the complaint was primary amenorrhea or delayed puberty. Over here, the complaint will be primary amenorrhea. The breast development is proper and they are going to say that menarche hasn't come till yet, right? Or they can come to you with complaint of inguinal hernia. So suppose you have a question which says that there is a female who has come to you with complaint of primary amenorrhea, right? Her breast development corresponds to Tanner stage 4 or 5, right? She has scanty pubic hair or axillary hair, right? And uterus is absent and inguinal hernia is present. Immediately you should think about complete androgen insensitivity syndrome. Clear to all of you? Okay. Now, what are the lab investigations which you are going to get in them? Now, to understand the lab investigation, I am repeating what I told you a few minutes back, that it is FSH which acts on Sertoli cells, and Sertoli cells are producing inhibin B, which has a negative feedback on FSH. Now, in these individuals, Sertoli cells are functioning normally, the testes are normal, so levels of inhibin will be normal, and if levels of inhibin B are normal, they will have a negative feedback on FSH, so levels of FSH will also be normal, right? Now, as far as LH is concerned, LH acts on Leydig cells, and Leydig cells produce testosterone. Now, because these individuals are resistant to testosterone, the levels of testosterone are high as compared to a female. When you will get testosterone levels done, you will be surprised that the levels of testosterone are high in comparison to a normal female. Now, these individuals are resistant to testosterone, and you know that testosterone has a negative feedback on LH and a negative feedback on GnRH. Now, because they are resistant to testosterone, so what is going to happen to LH? The negative feedback on LH will be lost, and so the levels of LH will be high, right? So what are the lab results which you are going to get over here? The lab results which you are going to get is testosterone is high in comparison to normal males, LH levels are high, inhibin is normal, and FSH is normal. A very important differential diagnosis of this condition is a 46XX DSD. Now, if there is a 46XX DSD where there is no uterus development, right? Here also you will see absent uterus. There also you will see absent uterus, right? And that is Mullerian agenesis. Mullerian agenesis and complete androgen insensitivity syndrome are very close differential diagnoses of each other. In both these conditions, uterus is absent, and in both these conditions, the external genitalia are exactly female-like, and patient is coming to you with complaint of primary amenorrhea. This was the reason I did not tell you Mullerian agenesis in 46XX DSD. After this topic, after androgen insensitivity syndrome, I'm going to talk to you about Mullerian agenesis. Now, in Mullerian agenesis, the genotype is 46XX. In androgen insensitivity syndrome, the genotype is 46XY. So if I ask you what is the confirmatory test for androgen insensitivity syndrome, the confirmatory test is karyotyping. Now, how are you going to manage them? Again, the same thing. They have exactly female-looking external genitalia. They have been reared like a female. So I'm going to let them be females. Now, because the testes are undescended, I have to do gonadectomy. But over here comes an important but. Now, in case of Swyer's syndrome, the testes were not functioning and they were prone to malignancy. That is why I told you that the moment you make a diagnosis, you should tell the parents that gonadectomy should be done as soon as possible. But in case of androgen insensitivity syndrome, testes are producing testosterone, and it is this testosterone which is getting converted into estrogen and is leading to breast development. Right? And because the testosterone is leading to breast development, and because we are letting them be females, so in this case, I am going to do gonadectomy, but only after pubertal development is complete, and that is around 16 to 18 years of age. Now, after I have done gonadectomy, again, I will have to give them hormone replacement therapy. And what hormone am I going to give? Because I am letting them be females, I have to give them estrogen. Am I going to give them only estrogen or estrogen and progesterone? In case of androgen insensitivity syndrome, the uterus is absent. Because uterus is absent, I am going to give them only estrogen. And again, the same thing, that because I am letting them be females, I will have to make them capable of getting married. So I am going to do a vaginoplasty in them. Technique will be the Weishetti technique, or you can also go for the conventional technique, that is McIndoe technique. So please remember, for vaginoplasty, we have a conventional technique which generally we don't do these days, which is called as McIndoe technique, or you can do it by laparoscopic method, which is the Weishetti technique or the Davidoff technique. These days, for any kind of vaginoplasty, we are using either the Weishetti technique or the Davidoff technique. The time for doing vaginoplasty is same for any indication, and that is just before or just after marriage. Now, just one question to all of you. Can these individuals have their own biological child? Can they have their own biological child? No. They cannot have their own biological child because their testes we are going to remove, and they don't have any ovaries, and that is why they cannot have their own biological child. The only method for them to become a mother is by adoption, right? Now, coming to partial androgen insensitivity syndrome, as the name suggests, there will be partial insensitivity to androgens. In other words, these individuals will be partially sensitive to androgens. Because they will be partially sensitive to androgens, that is why in them Wolffian duct will not regress. Wolffian duct will grow, but it will grow partially. And because Wolffian duct will grow partially, that is why male internal genital organs, that is SEED, would be present, but they will be present partially. In the other words, they will not be properly developed. By partially, I means they are not properly developed, right? As far as the external genitalia are concerned, again they are going to, because they are partially sensitive to testosterone, so they will be partially sensitive to dihydrotestosterone, and that is why they are going to have ambiguous genitalia. And these individuals again will be taken as a female child at birth. Right? And then everything is same for partial androgen insensitivity and complete androgen insensitivity. The only difference is that in complete androgen insensitivity, you had female external genitalia. Whereas in partial androgen insensitivity, there is ambiguous genitalia. Other than that, there is no difference in complete and partial androgen insensitivity syndrome. And other than this, that the internal genitalia are seen in partial androgen insensitivity syndrome, and the internal genitalia are male internal genitalia. But generally in questions, they are not going to ask you this. Generally, they are going to ask you a question like this. The framing of the question will be that there is a female who's come to you with complaint of primary amenorrhea. Her breast development corresponds to Tanner stage 4 or 5. Axillary and pubic hair corresponds to Tanner stage 1 or 2. And there is presence of inguinal hernia. Now, whenever you get a history that breast development corresponds to Tanner stage 4 or 5 and axillary and pubic hair corresponds to Tanner stage 1 or 2, immediately you should think about androgen insensitivity syndrome. Then in the question, look for what are they talking about the external genitalia. If they say external genitalia are female-like, that means the diagnosis is complete androgen insensitivity syndrome. And if they say external genitalia are ambiguous, then it becomes partial androgen insensitivity syndrome. Clear to all of you? Then comes management of partial androgen insensitivity syndrome. Again, there is just one difference over here. In complete androgen insensitivity syndrome, I was waiting for gonadectomy till 16 to 18 years of age. In partial androgen insensitivity syndrome, you have to do gonadectomy as soon as possible, because till the time testes will be there, testes are going to release testosterone and the external genitalia will become more and more male-like. And we are going to let them be female, so we do not want the external genitalia to look more and more male-like. That is why in them gonadectomy should be done as soon as possible. So in Swires syndrome and in partial androgen insensitivity syndrome, you have to do gonadectomy as soon as possible. Whereas in complete androgen insensitivity syndrome, you have to do gonadectomy at the age of 16 to 18 years. Then comes the the mildest form of androgen insensitivity, and that is what is Riefenstein syndrome. Now, Riefenstein syndrome, the child doesn't present to you as a female child. The child presents to you as a case of an under-virilized male child. The child will be a male child, but the virilization, that is the effect of androgens, would be less. Right? So they are going to present to you as male who are infertile with a bifid scrotum or a perineoscrotal hypospadias. And whenever you have a child with Riefenstein syndrome or an individual with Riefenstein syndrome, treatment is testosterone, and gonadectomy is done only if cryptorchidism is present. If cryptorchidism is not present, then gonadectomy is not done in them. Have you understood Riefenstein syndrome and have you understood complete and partial androgen insensitivity syndrome? Now, if you've understood this, then I told you that there is a 46XX condition which closely resembles androgen insensitivity syndrome. In both these conditions, there you will get a female phenotype. In both these conditions, breast development will be present. And in both these conditions, there will be absent uterus, and both of them are going to present to you as a case of primary amenorrhea. So whenever you have a female who's coming to you with primary amenorrhea and absent uterus, you have two differential diagnoses in your mind. One is Mullerian agenesis and the other is androgen insensitivity syndrome. So let's talk about Mullerian agenesis. Please remember, this is not a 46XY DSD, this is a 46XX DSD, but because it has close resemblance with androgen insensitivity syndrome, that is why I'm teaching you here. Okay? Now, What happens in Mullerian agenesis? In Mullerian agenesis, the genotype is 46XX, and because there are two X chromosomes and because Y chromosome is absent, that is why the gonad will be ovary and ovary will be normally functioning, right? And over here, there won't be any problem with external genitalia. Everything is normal. I'm not saying that they are exposed to some androgens in intrauterine life. Nothing of that sort happens, right? They are like a normal female, so the external genitalia will be like a normal female. Then what is the problem? The problem is that in this condition, both Mullerian ducts are absent, and because both Mullerian ducts are absent, so uterus will be absent, cervix will be absent, upper part of vagina will be absent, and fallopian tube will be absent. This is what is theoretical. Theoretically, we presume that all these structures will be absent because all these structures are derived from Mullerian duct, and both Mullerian duct are absent in Mullerian agenesis. Practically, what we see is that in some of these females, distal part of fallopian tube may be seen. Then practically what we see is that although it is only the upper part of vagina which is formed from Mullerian duct, the lower part of vagina is formed by urogenital sinus. So we expect that lower part of vagina should be present because it is not formed by Mullerian duct. But practically what we see is that in Mullerian agenesis, there is complete vaginal agenesis. Both the upper part and lower part are absent. So upper plus lower part absent. Then practically in some cases we see that a rudimentary uterine horn may be present. Uterus is not present, but a rudimentary uterine horn may be present, and that is the reason for endometriosis or dysmenorrhea in patients of Mullerian agenesis, right? So these are the things which you have to remember, that ideally in them, only upper part of vagina should be absent, but what we see is that there is complete vaginal agenesis. Ideally in them, both the fallopian tubes should be absent, but we see that distal part of fallopian tube is present. And over here, in some cases, you may get a rudimentary uterine horn. Now, because in them, uterus is absent, what is going to happen? Now, these females at puberty, first let us see what is going to be normal in them. Now, in these females, because ovaries are normal, so estrogen will be normal and so breast development will be normal, right? These females are going to ovulate normally and they are going to have normal levels of androgens. Androgen in a female comes from ovary also and from adrenal also, and over here everything is normal. Because everything is normal, their pubic hair and axillary hair will be normal, and this is the difference between androgen insensitivity syndrome and Mullerian agenesis. In androgen insensitivity syndrome, pubic hair and axillary hair were scanty, right? Over here, pubic hair and axillary hair will be normal. Right? Now, but because they do not have any uterus, now since uterus is absent, that is why these females are going to come to us with complaint of primary amenorrhea. And we also anticipate that because in them vagina is absent, when these females are going to get married, they are going to have coital difficulties. Although they come to us with complaint of primary amenorrhea, but then we know that vagina is absent, so they will have a problem with intercourse, right? Now, what are the associated problems which you can get in case of Mullerian agenesis? The associated problems which you can get in Mullerian agenesis are renal anomalies and skeletal anomalies. More common are renal anomalies, and the most common renal anomaly which you can get in them is renal agenesis or a horseshoe-shaped kidney. And the skeletal anomaly which you get is hemivertebra. Please remember that if a female has only Mullerian agenesis, it is called as MRKH type 1. What is MRKH? Mayer-Rokitansky Kuster-Hauser syndrome. So, if a female has only Mullerian agenesis, you call it as Mayer-Rokitansky Kuster-Hauser syndrome type 1. Now, if a female has Mullerian agenesis and along with that she has renal anomalies and skeletal anomalies, then it is called as MRKH type 2, or it is called as Merck syndrome. Now, what is Merck's syndrome? In Merck's syndrome, MU stands for Mullerian agenesis, R stands for renal anomalies, and CS stands for cervical somite. Right? So if there is a Mullerian agenesis female who along with Mullerian genesis has renal anomalies and skeletal anomalies, you call it as MRKH type 2. This means that in all patients of Mullerian agenesis, there are two investigations which you have to do. And what are the two investigations? Number one, you have to do an IVP, that is intravenous pylography, to detect any renal anomalies. And you have to do a skeletal X-ray to detect any skeletal anomalies. Apart from this, if I ask you what is the best investigation to differentiate between androgen insensitivity syndrome and Mullerian agenesis, it is karyotyping. Apart from that, if I ask you what happens to the levels of LH and FSH in Mullerian agenesis, you will say in Mullerian agenesis, everything is normal. She's ovulating normally. Her estrogen is normal. Her progesterone is normal. Everything is normal. So her LH and FSH levels will be normal. Whereas in androgen insensitivity syndrome, we saw that the LH levels were high. Right? Management. Can you make these females menstruate? No, we cannot make them menstruate because they don't have a uterus. But then we can deal with the problem of coital difficulties. And for coital difficulties, what you are going to do? You are going to do vaginoplasty. Conventionally, you can do a McIndoe vaginoplasty. Nowadays, you do a Vesheti procedure or a Davidoff procedure. The time is that you have to, when are you going to do? You are going to do it at the time of marriage or just before marriage. Now, can these females have their own biological child? Yes, they can have their own biological child because they are ovulating normally. So what I'm going to do is I'm going to do an IVF with their own eggs followed by surrogacy. That is how they can have their own child. Have you understood this? Okay. Now just one thing more. So I'm coming back to 46XY DSD. In 46XY DSDs, there is one more DSD which you have to remember, and that is a case where there is 5-alpha reductase deficiency. So if there is a 46XY individual and they have 5-alpha reductase deficiency, what are you going to get? See, because genotype is 46XY, because Y chromosome is present, that is why the gonads will be testes and they are normally functioning testes. If they are normally functioning testes, the Sertoli cells will produce anti-Mullerian hormone and Mullerian duct will regress. Now, because they are normally functioning testes, so Leydig cells will be normal and so testosterone levels will be normal. And because testosterone levels will be normal, Wolffian duct will grow and you are going to get male internal genitalia, that is SEED, seminal vesicles, epididymis, ejaculatory duct and vas deferens, all of them will be present. Now, the problem in these individuals is that testosterone is unable to get converted into dihydrotestosterone because there is 5-alpha reductase deficiency. Because there is 5-alpha reductase deficiency, so they are going to have female external genitalia and again they are taken as a female child at birth. Now again, when they are going to grow up, what is going to happen? At puberty, testosterone is present. Right? The testes are functioning normally, testosterone is present. So it is going to lead to development of male secondary sexual characteristic. So here we have an individual with external genitalia female, right? And male secondary sexual characteristic, that is deepening of voice, increase muscle mass, increase libido. In other words, plus what is going to happen? Because they are going to have testosterone. This testosterone is going to lead to virilization of the female external genitalia to some extent at puberty, not at birth. At birth, this didn't happen. But at puberty, there will be some virilization of the external genitalia. The clitoris will be enlarged, so there can be a clitoromegaly. It could appear as if there is a clitoromegaly. Now, over here, testosterone is present, but estrogen is not present, so there won't be any breast development. They have entirely secondary sexual characteristics of males, right? In case of androgen insensitivity syndrome, the levels of testosterone were very high, right? They had insensitivity to testosterone, so testosterone was getting converted into estrogen. Over here, the levels of testosterone are not high and they are sensitive to testosterone, so testosterone will do its own function. It will not get converted into estrogen. So breast development will be absent. And because there is no dihydrotestosterone, they will have less body hair, they will have less acne, and they will have less temporal hairline recession. In order to make a diagnosis of this condition, I have to measure testosterone is to dihydrotestosterone levels. And if the testosterone is to dihydrotestosterone levels is more than 10 in an infant or more than 20 in older children or adult, then you make a diagnosis of 5-alpha reductase deficiency. Clear? Now, once we've done 46XY-DHD, let's do quickly a few important questions. If I ask you what is the most common cause of male pseudohermaphrodite, what do you understand by this term male pseudohermaphrodite? Male pseudohermaphrodite means we have a 46XY individual whose external genitalia are exactly female looking. So what is the answer? The answer is androgen insensitivity syndrome, complete androgen insensitivity syndrome. So what are the other conditions where you can have a 46XY individual with a female-looking external genitalia? The answer is Swyer syndrome and 5-alpha reductase deficiency. Right? Be very careful what the question is asking you. They are asking you most common cause of male pseudohermaphrodite. But if they ask you what is the most common cause of 46XY individual with ambiguous genitalia, then the answer is partial androgen insensitivity syndrome. Clear? Now comes the list which I was telling you that we are going to do it at the end. Write down all causes of ambiguous genitalia in 46XX and XY individual. Right? Or causes of clitoromegaly at birth. So in a 46XX individual, congenital adrenal hyperplasia, you know what, due to which enzymes. Then ovotestes, aromatase deficiency and maternal exposure to androgens. In 46XY individual, partial androgen insensitivity syndrome and congenital adrenal hyperplasia, and you know due to which enzyme deficiencies, due to the 17 enzyme deficiencies. Clear to all of you? Along with that 3-beta HSD or P450 OR, which leads to ambiguous genitalia in both males and females. Have you understood this? Have you understood entire DSD? See, DSD is like your mathematical tables. If you know the tables well, it is very easy to do maths. Similarly, if you know normal sexual development well, then it is very easy. The DSDs are very, very easy. And you get many questions on DSD. That's the plus point, right? So if you know disorders of sexual development well, if you know the concepts behind them well, you will never do any MCQ incorrect on them. Now, I have a request for all of you. Immediately after doing DSDs, if you are going to watch any other video, that video should be the video on primary amenorrhea. Many of the concepts in the video on primary amenorrhea are overlapping with DSD. Okay, have a great day. Keep studying. Bye-bye.